Good afternoon. We'll get started with the webinar in just a few minutes. Thank you for joining today's webinar. Stay hydrated, stay healthy, reducing dehydration risk in older adults. My name is Chris Glenn. I'm the Director of Sales for Personal Nutrition Solutions for Thicket and Squincher brands. I will be today's moderator. As required by accrediting organizations, here are the disclosures for our moderators and our speakers. Our speakers today are Dr. Alexander Jacobson, Dr. S. Andrew Cage, Katrina Woodward, and Margaret Roche. Dr. Alexander Jacobson practices a double board certified physiatrist and sports medicine physician and the assistant professor of medicine at the University of Texas Health Science Center at Tyler, where he also established the first outpatient PM&R clinic within UT Health East Texas. He enjoys being active in teaching roles within the Sports Medicine Fellowship, several physician residency programs, as well as medical school through the UT Health Science Center at Tyler. Clinically, he practices a mix of outpatient PM&R and sports medicine, and he is fortunate enough to be one of the head team physicians for the University of Texas at Tyler and their Division II athletic programs. Dr. S. Andrew Cage just completed his 11th year at the head athletic trainer at the award-winning athletic training department at the University of Texas at Tyler in 23 and 24. As the head athletic trainer, Andrew oversees a staff of 7 certified and licensed athletic trainers and provided medical coverage for UT Tyler's intercollegiate athletics programs. Cage completed his doctorate of education in kinesiology through the University of North Carolina, Greensboro, in August of 2021. Katrina Woodward is a speech language pathologist with 19 years of specialty experience evaluating and treating adults and geriatric patients with cognitive communication deficits and dysphagia. A consummate professional, a proven leader, a dedicated mentor, and a patient advocate with passion for evidence-based practice, Katrina currently serves as Chief Administrative Officer for SDX Dysphagia Experts, Massachusetts Speech Language Hearing Associates Vice President for Education and Planning, and a US IDDSI reference group volunteer of co-chair of the Communications and Newsletter Committee. Margaret Roche is the founder of Roche Dietitians, a nationally recognized leader in nutrition consulting. Maggie's mission is to educate and empower those who nourish others. Maggie is a registered dietitian with a master's degree in clinical nutrition. She has an advanced credentials as board certified as specialist in gerontological nutrition and is distinguished as the fellow of the Academy of Nutrition and Diuretics. There will be 3 polls through the webinar. and time for questions and answers at the end. You can add your questions in the Q&A feature on your screen. For those attending live, you will receive an email tomorrow with links that will for the continuing education certificates. Welcome to our webinar.
Thanks very much, Chris. I'm going to turn my camera off. I think that helps with our reception and bandwidth. Okay. Thanks very much, Chris. Welcome, everyone. I want to reiterate that for those attending live, you will receive an email tomorrow morning with this link to the CEU. There are no handouts for today. This session will be recorded and will be available to you. We'll send you an email about that when it is available, which might take us a few weeks to get it up. Okay, let's get started and look at our learning objectives for today. So today, by the end of the hour, we put some great things together for you. So our objective for you by the end of the hour is for you to be able to describe the normal fluid and electrolyte needs of the older adult, and the serious consequences of not meeting them. You'll be able to recognize the signs and symptoms of underhydration and dehydration. You'll be able to identify how managing underhydration is the key to avoiding dehydration. And you'll be able to describe how strategies adopted from the athletic trainer and physician can be used to support hydration in frail older adults. And that's really interesting. I can't wait for you to hear all of that. And maybe most importantly, you'll be able to share best practices for meeting hydration needs for the older adult. Let's get right into our first polling question. The question is, how concerned are you about underhydration and dehydration in the population you serve? I am going to launch that poll and give you all, whoops, I got to select it first. Give me a second. How concerned? And launch. So you should see the poll right now. Go ahead and start filling that in. And your options are, the population I work with does not have underhydration, so not concerned at all. You're concerned, but there's not a way for you to address it. And C, you're concerned and you have a role in identifying and addressing it. And we'll give it a few more seconds for everyone to vote. And then I won't be able to see the results, but Chris will read them out to us. You're still voting. I can still see it moving. Okay, I'm going to close it and I'm going to share it. Can you see the results, Chris?
Yes, I can. Sorry, my chat box is blocking that. So give me just a second. I'll shrink that up. Yes, so by far, question 3 by 86%, and then 2 with 11, and then 5% with the first question. So overwhelmingly, question 3, 86%, nothing in the chat.
Okay, great. Thank you. And we're going to see through our discussion that, if you work with older adults, they are at risk for underhydration and dehydration just by the mere fact that they're older adults. So anybody in the A category is going to learn today, again, if it's older adults, that their population that they work with, they do have a need for concern. And then hopefully for those who have a concern but not for a way to address it, we're going to give you some ways to address it. So, and those who have some ways, we're going to enhance those ways. So very exciting. Thanks for participating. I'm going to move on and hopefully the slide will advance. And let me know if you don't see the next slide, but we're going to go ahead and get started with our content. So water is vital for life. It's involved in nearly all physiological processes.
Maggie, your slides aren't working.
Okay, thank you for letting me know. So the slide is closed. Let me try it again.
You're good.
How about, I'm good? Okay, thank you. All right. Water is vital for life. It's involved in nearly all physiological processes, and optimal health is dependent on the maintenance of adequate hydration and electrolyte balance. You can see why water is sometimes called the forgotten nutrient. Water is essential both extracellularly and intracellularly. Throughout the body, water is the medium for transport. It supplies nutrients and removes waste. Inside cells, where 2/3 of the body's water is, It acts as the solvent for biochemical reactions and absorbs heat from those reactions, processes. Physiologically, water is central for maintenance of the circulation and the lymphatic system, body temperature, removal of waste products from the body, facilitating digestion, acting as a lubricant, and flushing out the urinary tract, eyes, and other crucial organs. So that's why we say water is vital for life. Now I'm going to hand it over to Dr. Jacobson, who's going to add to this.
Yeah, thank you so much. So certainly changes with aging are going to be a recurring theme today. And one of the big things to note is that as we age, the actual proportion of the fluid in our body reduces. So we start with over 70% of our weight as newborn babies being total body fluid, total body water. This decreases to 60% in childhood and continues to decrease to about 50% in older adults. As that total body water percentage falls with age, we also see there's a decreased capacity to buffer against dehydration. That can obviously have serious consequences in regards to health and well-being. In general, the fluid needs of the older adult are multifactorial. So for example, the European Food Safety Authority recommends an adequate water intake of around 2 liters a day for women, 2.5 liters a day for men. That's to maintain urinary osmolarity and water consumption. Assuming 20% of our total water intake comes from our food, this roughly equals out that women will require 1.6 liters a day and men about 2 liters a day. These recommendations, though, are based on healthy adults over 18 with no additional considerations. There are multiple external and internal factors that can change these values, including things like overall body composition, energy consumption, temperature, climate, and the same normal changes that occur with aging that we just reviewed. Additional changes that are associated with aging include a gradual decrease in the thirst response or a blunting of that response to thirst, especially if it's slow changes over time in that plasma osmolality. There are kidney function decreases, which result in a decreased ability for the kidneys to maximally concentrate the urine to preserve more water. Without fluid intake, death can occur in as little as a few days to a week, and this is far quicker than with the absence of any other nutrition. Overall, these chronic diseases that are typically more prevalent in the older population can impact all phases of this normal water homeostasis. Moving on into specifically into electrolytes, we know that sodium and potassium are highly interrelated. They're essential nutrients and they play vital functional roles in the body, including being important for nerve signal transmission, muscle contraction, fluid balance. We know that these recommended dietary allowances are based on median intakes of healthy adults, but we need to make sure we consider how additional chronic disease, medications, and things like frailty may impact some of these recommendations. For example, compared with a non-frail group, there was a study that identified that a mild and moderately frail group tended to have hypernatremia and hypophosphatemia, whereas a severely frail group tended to have dysnatremia, so either high or low, hypokalemia, and hypophosphatemia. So again, associating that frailty was highly associated with multiple electrolyte abnormalities. If we move along to the next slide, we can get into the total water requirements. Now, this includes all water contained in everything we take in, food, beverages, drinking water. Because healthy individuals have considerable ability to excrete excess water and thereby maintain their water balance, an upper limit was not necessarily set for the general healthy population. However, we also know that there are cases of acute water toxicity, and that's been reported after rapid consumption of very large quantities of fluids, essentially exceeding the kidney's ability to excrete that, which roughly is equal to somewhere between 0.7 and 1 liter per hour. In general, when we look at these dietary recommended intakes, we need to have a couple of definitions we look at. So many of these nutrients and fluid intake recommendations were made by combining various recommendations from both US and Canadian government agencies. So in general, when we talk about the RDA, this is an average daily dietary intake level sufficient to meet the nutrient requirements of nearly all healthy individuals in a group. It's calculated from this estimated average requirement, or the EAR, and if sufficient evidence is not available to establish an EAR, and therefore an RDA, we use this AI, or adequate intake calculation. For AI, the adequate intake for the majority of adults and gender groups is believed to cover the needs of all the healthy individuals in that group. But again, the lack of data or the uncertainty in that data prevent being able to specify with confidence what percentage of individuals is covered. When we look at sodium and potassium, we can see that this dietary recommended intake, or adequate intake, is around 1,300 milligrams per day for people aged 51 to 70 and 1,200 milligrams per day for people over 70. Comparing that to the upper limit for sodium of 2,300 milligrams per day. Now, the dietary guidelines for Americans recommend that adults consume less than that 2,300 milligrams of sodium per day. But we also know from large studies that average American consumes more than 3,300 milligrams of sodium per day. As of 2019, there was not an upper established limit for potassium. So you can see that on the far right side of the table, as there wasn't enough evidence to determine one for healthy people in the population. In general, the body is good at being able to get rid of excess potassium in urine. It's not entirely clear as a generalizable fact how much potassium can be safely consumed. However, we do know that high doses of potassium can be dangerous, and there are some groups that may need to be cautious about their intake. Additionally, if we rewind back to March of 2019, the recommended daily potassium intake for adults was actually lowered from 3,400 milligrams for men and 2,600 milligrams for women. That was a significant decrease from what the prior recommended amount was, which was 4,700 milligrams per day. When we look at potassium at the population level, fewer than 5% of Americans were able to meet their daily recommended potassium intake. And so decreased potassium recommendations combined with mandatory labeling of potassium on the products was a hopeful approach to get Americans closer to achieving that recommended daily potassium intake. We can go ahead and go to the next slide, where we'll briefly look at calcium and vitamin D being two other high impact minerals and nutrients that tend to be focused on. I won't go belabor the points on this, but again, these dietary reference intake and recommended dietary allowance levels vary not only between age, but certainly within certain medical conditions or comorbidities.
And then when we're looking at this from a sports medicine perspective and athletic training venue where we're working with competitive athletes, it's always interesting to me whenever I'm having conversations with individuals about how much people are having to increase their electrolyte intake if they're participating in sports. And so if we look here at the recommendations that are available, you'll see that pretty much across the board, everything stays roughly the same. The one thing we look at is with the fluid and water intake. Women and men are still starting at that 1.6 to 2 liters per deciliter in terms of how much hydration they should be getting. Now, at the same time, as people's activity increases and they start to change up the environment that they're doing exercise in, and we take a look at the types of exercise that they're using, it's going to be something that's going to be important for us to note because we may have to increase that. And we'll talk a bit later about some of the methods in which we do that. What's particularly interesting to note, though, is the fact that even in our general athletic populations, we don't necessarily increase our electrolyte intake until we get to those elite level endurance athletes. And then once we get to that point, we're really only increasing our sodium to about 2,900 micrograms or milligrams per day. And then with potassium, we're only bumping that up by about 400 milligrams. So a lot of times when you see some of these products that are out there that promise you 100% of your necessary electrolytes, a lot of that's being excreted as urinary waste because these individuals are getting more than their body's actually needing, even for these elite level activities that they're performing.
now we need to go into how much of this is an actual issue. What is the prevalence when we talk about dehydration as an entity, right? So we know from well-done studies that older adults are at risk for dehydration. Dehydration in general is more highly prevalent in hospitals and tends to increase in various levels of hospitalization and supervision as far as home versus nursing home versus more of an inpatient setting. We know that adults older than 65 have the highest hospital rates, admission rates for dehydration specific causes. We also know that nursing homes have identified inadequate fluid intake among anywhere from 50 to 90% of their residents. So dehydration accounts for a significant amount of preventable emergency room visits, and that's across the population, certainly in the older population. If we go to the next slide, I think it's also useful to define when we talk about dehydration, what does that mean? Dehydration is simply the state when the water losses exceed the ability to replace those losses. This results in lower total body water. It's obviously a complex condition resulting in that and has far-reaching effects that we'll go into. If we can go to the next slide, we also need to differentiate what type of water loss there is. For example, water loss can be in the form of excessive blood loss, vomiting, diarrhea. All of those have been termed salt loss dehydration. That type is typically associated with electrolyte losses as well as water. If we contrast that with the salt loss dehydration with water loss dehydration, that's where electrolytes can actually be stable or even elevated. Inadequate water intake is the primary cause of that water loss dehydration. And some societies have even dubbed that subtype a low intake dehydration instead of a water loss dehydration. The overall effect of that water loss dehydration or inadequate water intake is an increased concentration of particles in the body fluid. Osmolality is the definition of that and is the objective concentration of those particles within the total body water. So some additional specific definitions that have been used include measurements of osmolality up above 294 milliosmoles per kilogram, or a total weight loss of greater than or equal to 3% below baseline. These values are great from a binary standpoint, yes, no, in or out. However, application is typically difficult when you start getting into a cost, comfort, and feasibility standpoint. But how do we measure this across certain phases of care?
And as we were preparing this presentation and Dr. Jacobson was bringing this information to the table, I thought it was interesting because clinical dehydration, again, starts at that 3% body weight loss. In our athletic population, though, if we have a patient that experiences a 2% body weight loss, they start to experience deficits in terms of both cognitive and physical performance. And we try to make sure that we measure this sooner rather than later, because at the end of the day, these individuals are trying to compete and perform physical activity at a high level. And so seeing that 2% decrease in body weight already having an impact on those things gets to be concerning. And whenever we take this and look at it through the framework of older adults who might be living in nursing homes or assisted living centers, or are possibly even just receiving outpatient rehab and then making use of the nutrition facilities at that outpatient rehab clinic, if they're having decreases in their cognitive and their physical performance as well, then that can create its own set of issues when you're trying to help these individuals continue to live their lives as independently as possible. And it does create a logistical challenge if we're having to try to weigh patients daily and then weigh them before and after activity. But because it's something that's so important, depending on the infrastructure that you're working in, it's important to do what we can as far as these things go. So in our clinic with our athletes that we work with, we will typically look for our higher risk athletes. So these might be people that are working out outside during hotter, more humid times of day. And then we'll do our weigh-ins before and after practice to make sure they're not dropping below that critical level. When we're looking at our older adults and our patients that might be getting seen by some of our attendees, it may be interesting to explore flagging some of those patients that might be considered at higher risk. So your patients on diuretics or your patients with renal conditions that might be more predisposed to dehydration. But again, I just felt like it was going to be something noteworthy for us to pay attention to. And then as we kind of move on and some of the other considerations that we have within the sports medicine setting and when working with athletic trainers that are working with these physically active individuals, we have to, again, keep in mind that we might need to increase their fluid intake above that 1.6 to 2 liters. And we mentioned it briefly before, but some of the reasons that we may end up doing this really would have to do with the types of physical activity that that individual is performing. So if they're increasing the intensity of their activity and the amount of workload they're putting on themselves, if they're increasing the amount of times that they're working out or practicing and competing, and then if they're competing, how frequently they are going from day to day. And again, kind of our carryover with our patients and the older population would be if they're having to come in for therapeutic exercise and rehabilitation, we want to be mindful of how often they're coming to see us, what other activities they're doing outside of the rehabilitation that they're doing with us, and just what that patient's specific goals are, because that's going to give us an idea of what kind of demand that physical activity is going to place on them from a hydration standpoint. Other things to consider would be those environmental factors. So we touched on it before, but hot and humid environments, you're going to see typically more loss of body fluid through sweat. So we're going to have to increase our fluid intake, especially in the summer month if you are somebody that lives in those climates. And then also the types of equipment and training equipment that those patients are wearing. So in our case, these would be people like football players or hockey players that are wearing a lot of pads. But having a wife that has worked as an occupational therapist in the skilled nursing facility setting, I know that they have a lot of patients that will want to wear sweatpants and sweaters or heavier clothing because they get colder, but that's also going to increase their sweating and also decrease their amount of fluid that they have on themselves. And that touches base on our last portion of this. As you can see with our athlete in our picture here, sweat rate is going to be another big factor that is somewhat individual. And a lot of times you're not going to take the time to quantify how much sweat somebody's losing, but it is something to keep in mind. And so if you have patients that as they're doing their exercises, they're sweating more than others, well, you're physically seeing those patients losing water through that sweat. And so we have to be mindful of that as we're trying to recommend what kind of fluid intake that patient specifically needs on their side of things.
Now, as we get into this more, how do we kind of start to identify this? We know underhydration is prevalent because it may not be easily identifiable with certain symptoms. We'll get into that more in a couple slides. We also know that older patients often don't pay attention to their fluid intake. And again, this is multifactorial. Along with that, these older adults do have normal physiology changes that blunt that thirst response. That's especially problematic when these changes are slowly occurring over time. We also know that it's estimated that up to 40% of community dwelling elderly people may be chronically underhydrated. We know that underhydration leads to more severe dehydration, and as a result, sometimes life-threatening infections and other health problems. Of the bubbles in this picture that you see, each of those domains can act both as a cause of underhydration and dehydration, as well as a secondary consequence due to this abnormal water balance. If we take a couple of these key examples, for kidney function, for example, in chronic kidney disease, water balance is significantly affected, both by changes to the kidney or even the medications used to treat it. Secondarily, if we add poor intake on top, that increases the demand on the kidney to concentrate that urine and conserve water. Both can create acute kidney injuries as well as potentiate that chronic kidney disease. From the neurological side, consider the physiologic impairments of someone with dementia and the impact that has on decreased intake, but also how that poor intake can then turn around and lead to that fatigue and confusion to perpetuate that problem. We'll touch on some of the additional medical issues related in a little bit, but if we go to the next slide, in identifying this issue, we know that adults over 65, especially residents of nursing homes and long-term facilities, and even more so those with chronic higher disease burden, have the highest rate of chronic dehydration and secondary hospitalizations or secondary health outcomes. Diagnosing this starts with clinical impression, but ultimately we may still have to rely on urine or blood testing. In that specific population, the difficulty is in differentiating multiple overlapping symptoms from dehydration with either normal changes of aging or findings due to other chronic illness, knowing that multiple variables can affect this fluid balance. There's some scenarios where the answer may be black and white. You have someone with a concern for acute infection, poor intake, and blood pressure changes. That person's likely going to need not only oral repletion, but IV supplementation. But at times it's a rule out game. Let's say a resident of a long-term facility has some acute changes in behavior. The question is there an acute illness? Is there family social issues? Is it kind of a one-off night of poor sleep? Did their daily weight show they were another 2 pounds down today? So sometimes enlisting additional resources such as family, facility, staff, nursing, nutrition, using that entire team as a tool can help provide additional insight. Typically, unless there's another contraindication, such as kidney disease, liver failure, heart failure, to name a few, encouraging oral fluids is always a good start. We'll have some pro tips on that in a bit. But ultimately, if there are already insurmountable losses, or if there's significant barriers to intake, it may cause a lower threshold for supplementation. Let's start with some of the physical findings that we look for. So if we go to the next slide, we have somewhat of a long list of some typical physical exam findings that have been associated or evaluated in looking for dehydration. If you want to go ahead and throw up that next line as well, there's a kind of the second column on this is some of the causes that can be linked with this. There was a large study that took all of these different findings and looked to see which of these was actually able to predict the diagnosis of dehydration. Turns out only 2 of all of these had any statistical impact or ability to predict dehydration, and that was fatigue and missing drinks between meals. So you can see from all this long list of findings, the majority of the things we're able to clinically assess or the causes that we can expect to make an impact or use to our advantage may not have any true clinic validity. Again, we need to take all of these with a grain of salt, and there's always going to be a time and a place. But from this large study, these may be 2 that we need to pay extra attention to. So if we go on to the next slide, how then should we identify this low intake dehydration or underhydration? If the old skin turgor or pinching of the hand is not going to be a sufficient standalone exam finding, well, then we maybe shouldn't use in isolation some of those findings, right? If you're in a resource or in an area where you have resources to be able to look at serum osmolarity, that's a great first step. Again, a binary objective measure. Physical signs and symptoms can be used clinically, and especially if you're able to observe for any changes in that patient, again, utilizing that healthcare team, kind of that whole approach. If there's changes, even if any specific finding is not in and of itself significant, it can still give you an idea or a trend towards some significant findings.
And when we're looking for these physical signs and symptoms in the athletic population, a lot of them are going to have carryover from those that Dr. Jacobson already mentioned. So these patients may end up presenting with fatigue, thirst, headache, or lightheadedness. If that dehydration also accompanies muscle fatigue or an electrolyte imbalance, we may have muscle cramping occurring. But it's most important to note that before any of these signs and symptoms have occurred, those patients are already going to be dehydrated before they start to present with clinical symptoms. So it makes it even more important for us to try to find ways to be able to prevent dehydration, and because it's going to be much easier than trying to treat dehydration. So that's why during those hot summer months with our outdoor sports and our higher risk athletes, we still do our weigh-ins and weigh-outs. So that way we can be monitoring their weight, but we don't rely on that as our only strategy. We have a team of athletic trainers, team physicians, and a clinical dietitian that speak to our teams about the importance of hydrating, not just with water, but also with beverages that contain carbohydrates and electrolytes. And we try to speak to them in a manner that they can understand. And that's something that's going to be valuable with anybody that we work with, because you have to remember that you're teaching to an individual. And depending on what phase of their life or their education they're in, or maybe they're from a different culture, we have to try to find those common grounds with these patients to be able to have those conversations and then effectively be able to emphasize the importance of proper hydration behaviors with these patients.
So now we've been able to identify, but at a system level, what does this actually mean as far as the outcomes go, right? So we know from well-designed studies, dehydration in older adults is associated with a longer length of stay, with increased likelihood of readmission, and with significantly increased healthcare costs. One of the larger studies, this was back in 1999, looked at dehydration as a primary diagnosis and found that it was not only did it have these correlations, but it was costing the system over 1.14 billion with a B dollars that one single calendar year alone. Adjusted for inflation, that would be over $2.5 billion related purely to admissions as a result of dehydration.
Wow, that's fascinating. And additional consequences of underhydration and dehydration besides the cost include an increased risk of morbidity and mortality, meaning that a person with dehydration is more likely to get sick and more likely to die. A person with dehydration is more likely to have constipation and more susceptible to infection. Dehydration causes delayed wound healing, and of course, for those who are dehydrated, they're more likely to be malnourished. And vice versa, malnourished people are more likely to be dehydrated. And especially now with the increased attention to malnutrition risk identification, we need to remember that as we identify those with malnutrition risk, we're probably identifying a person with dehydration risk as well.
Looking at the overt symptoms of lower hydration may not be visually evident when you see the patient, but it can be identified through comorbid diagnoses like UTI and in changes in behavior and function with acute confusion, exhaustion, and falls. At any time when we identify a change in status in a long-term care resident, we really need to rule out dehydration as a contributing factor at the start of the resident assessment. Ask yourself, is this resident sleepier than usual? Check your intake records for changes in fluid consumption. Is the resident less steady on their feet, or are they needing more assistance with their ADLs? Again, check that fluid intake. Is the resident suddenly not wanting to get out of bed for their meals? Are they feeling a little more lethargic? Check that fluid intake. Is the resident confused or disoriented when usually they are not? Back to that fluid intake, check those levels. Ruling out underhydration as a primary contributing factor should be a top priority. It is something we can reverse and monitor, and we can really limit the negative impact on our nursing home population. Like Dr. Jacobson stated, our concerns for dehydration in residents in long-term care are not just acute. Excessive water loss from vomiting and diarrhea is always a concern, but we are much more attentive to the possibility of dehydration when this type of acute illness occurs. We are ready to monitor hydration when we know a resident is experiencing excessive fluid loss. It is much more challenging for us to attend to the risk for persistent underhydration. Insufficient fluid intake over prolonged periods of time is a lot harder to identify because those symptoms may be more gradual. And in our elderly and our nursing home population, they may be masked by other diagnoses with similar symptoms. Consider this common scenario. Since Mrs. Jones had the flu 2 weeks ago, she hasn't been drinking much because her throat's been so sore. She's been taking throat lozenges, but they leave an unpleasant taste in her mouth and they make her food and her drinks taste terrible. She has had 2 witness falls, which staff had attributed to her recent illness due to fatigue and deconditioning. But could these falls also be symptomatic of underhydration? Absolutely, without a doubt. As a default practice, we should always evaluate hydration in our residents with falls or UTIs and or with a new onset of confusion or exhaustion. Older adults often respond to changes in their health with increased confusion. And unfortunately, that confusion then predisposes our elders to falls and increased dependence for activities of daily living. And with decreased mobility, there is also increased risk for opportunistic infections to strike. Pneumonia is one of those most prevalent in our long-term care population.
We've mentioned in multiple ways that this issue of underhydration and dehydration has so many different variables. Let's get into this a little bit more. So we mentioned how there are age-related decreases in the sensitivity to thirst, as well as changes in kidney function, making the kidneys less able to conserve water. We've also talked about how there's age-related decreases in that total body water, resulting in essentially a greater propensity for dehydration with less buffering ability against smaller changes in fluid intake. Certainly medical conditions, both acute and chronic, have a wide variety of contributions, and we'll break that down further in a minute. Medications are certainly another one to be aware of, and we'll go through that on the next slide. There's obviously a host of other issues that go right along with this in regards to cognition, dysphagia, other both social, physiologic, anatomic, logistical barriers. But if we get into some of these other issues regarding the medications, so there was a study in 2017 that looked at the top 20 medications sold or prescribed in the US. 19 of those 20 had side effects that included dehydration symptoms. So some of the more common ones, such as diuretics, especially loop diuretics, which reduce the dilution ability of the kidneys, thiazides that promote sodium loss, or any of the potassium-sparing diuretics, multiple different diabetic medications that induce glucose excretion in the urine, such as the GLP-1 agonists or the newer SGLT2 inhibitors. Certainly laxatives, such as the most commonly used Miralax, promote free water loss. There's multiple antipsychotics, such as lithium or the newer psychotropic medications. These have multiple effects, interfering with arginine vasopressin release. It can cause diabetes insipidus and cause hypernatremia. The SSRI class and duloxetine is known to cause ADH secretion and can increase sodium excretion. Multiple opioid derivatives also have effects with ADH secretion and can increase sodium excretion. And obviously, chemotherapy could be its own hour-long lecture in regards to the far-reaching effects. If we go to the next slide and we start going into some of these specific medical conditions, certainly in our elderly and longer-term facilities, acute conditions can include anything that may induce fluid loss. So we've mentioned vomiting, diarrhea, bleeding, drainage from wounds. Can also include anything that decreases the intake or the absorption, whether that's just malaise from a viral URI, an intestinal obstruction, pancreatitis, GI bleeding. The all prevalent diabetes causing this excessive glucose excretion in the urine. Issues like cystic fibrosis, which specifically cause excessive sodium chloride excretion in the sweat, which confusingly depletes water without necessarily changing plasma concentrations to cause a compensatory intake. So they lose salt and water without triggering a thirst response. Kidney disease having multiple effects in reducing the ability to concentrate urine, causing a resistance to hormonal feedback mechanisms, and causing dysregulation of this intra versus extracellular fluid balance that we need. There are, on the other side, some medical conditions associated with fluid retention. And so there, in certain cases like heart failure, certain renal dysfunction, or severe liver disease, we may actually want to restrict fluid intake in regards to trying to help balance this fluid.
We talked about the impact that dehydration can have on the cognition of all folks, from young to old, but one of our most vulnerable populations, that's our residents with dementia. The negative impact of dehydration is multiplied for our residents with dementia, resulting in additional cognitive and physical complications. For our residents with dementia, the negative impact of dehydration is truly multiplied because those changes in taste, smell, and even the ability to recognize the body's signals for hunger or thirst co-occur with advancing dementia. And so it further compounds the likelihood that dehydration will occur for these folks. Now I can't see you all behind the scenes, but as we go on to the next slide, just do this little exercise with me. Raise your hand if you've had a resident in long-term care say to you, I stopped drinking because it was making me cough. I bet there's a whole lot of hands up, like almost 600 of them. The more severe the degree of swallowing difficulty is for our residents, the more likely that resident is going to suffer from dehydration. The research indicates that dehydration occurs in 19 to 100% of our residents with oropharyngeal dysphagia. And obviously the impact is increased with the severity of that swallowing difficulty. It really does behoove us all in long-term care to be aware of the constant changes that our residents are going through.
Some additional causes or other barriers for dehydration include problems with mobility. A person with poor mobility simply can't get themselves to where the water and other beverages are. And this is just not limited to walking. A person could also have difficulty, for example, lifting the glass of water, which could be perceived as quite heavy for a frail older adult, or have other physical limitations such as a tremor that get in the way of being able to drink. From a practical perspective, if an older adult does not have access to water and other beverages, they're at risk for dehydration. And additionally, researchers have found that a significant psychological barrier is the fear of incontinence that would then affect the amount of water they drink during the day because they're worried about incontinence overnight.
And when we start to think about the issues that we run into when it comes to psychological barriers, we also have to look at what barriers we may have to patients going about taking care of themselves from a rehabilitative standpoint and doing the therapeutic exercise necessary for them to get back to their activities of daily life. And dehydration certainly just adds to this issue because as individuals become more dehydrated, like we mentioned before, we get that decreased muscular performance. These patients will present with decreased muscular strength and decreased endurance. And while cognition does decrease as individuals get dehydrated, one thing the body actually gets better at is sensing pain. So the sensation of pain will increase when we're dehydrated. And this is going to be across the board, whether it is a patient in a nursing home or it's a collegiate athlete that somebody's working with. And when these individuals are having this decreased muscular strength and endurance and that increased sense of pain, it's going to have a negative impact on their motivation. And we mentioned before that these signs and symptoms are going to show up before or after this person's dehydrated, but a lot of times that thirst response, especially like Dr. Jacobson mentioned, in these patients where that response is blunted, isn't going to show up before that patient's dehydrated. And so if we're relying on this, it's going to make this problem an issue that becomes even larger. And if we move on to the next slide, we really talk a little bit about how these patients that are attempting to do their rehab are already kind of behind the 8 ball at this point. And anybody, myself included, does not like to fail or struggle at tasks. We like to feel like we're doing things well, and we like to feel like we're succeeding. And so if we're not succeeding in rehab, or that patient's not succeeding in rehab, then their motivation's just going to go down the drain. And if this patient shows up and they're dehydrated, that's only going to make this an even bigger struggle for them because they're already at that decrease in strength and muscle endurance that would be helping them be able to perform their exercises. So when these patients are showing up for rehab, it's important for us to make sure we're checking in with them because especially in these older populations, they may not even realize that they've become hypohydrated. And this is a practice that I use even with healthy 18 to 24-year-old college athletes, but it's important to make sure you check in on your patients before you start them on exercises. Main questions that I always start with are, have they been drinking water or sports drinks recently? Have they been eating? When's the last time they had a meal? How did they sleep the night before? And then I always make sure I ask how they felt after their last session with me in terms of how they felt after their exercises and their treatment. And then based off of this, we kind of left that last line open-ended because as you're checking in on these patients, you're going to have follow-up questions based off of each of these. And depending on how that patient presents that day, then I will be able to adjust their rehab. If I know that all these things are optimal, they've been hydrating and eating well, they got a good night's sleep, they didn't feel too sore, but they felt like they got challenged last time, I know we can either advance their exercises or at the very least maintain where we are at with our exercises. And if they did maybe have some of these variables that put us in a position where it's going to be a situation where they're struggling, then I know that we maybe need to cut back on some sets or some reps, or we maybe need to cut back on the resistance or increase their break time in between exercises. So that way we can put these patients in the best position possible to succeed as they're performing their rehab.
So in assessing dehydration, obviously the first goal of treatment is to restore circulating volume. We need to be able to have hemodynamic stability to have anything else relevant happen. Second goal, identify the cause or the underlying contributions to prevent it from recurring again. And then we need to also be able to strive to identify and prevent underhydration as a precursor to the dehydration state. And again, that prevention being key.
And in terms of what the hydration needs of the older adult are, Dr. Jacobson already showed us the dietary reference intakes. I just want to throw this formulation up for folks who may not be familiar or who may not be calculating fluid needs, but we basically go with a baseline of 30 milliliters per kilogram of body weight or a minimum of 1.5 liters a day for older adults. And because the hydration status of older adults is tenuous, we want to make sure that we're individualizing that. And then here's just a few other examples. I'm sure most of you who are working in at least the dietetic side of things are familiar with these calculations. For people who have fluid restrictions, we can go as low as 20 to 25 milliliters per kilogram, but in general, we go with 25 to 30 milligrams for average adults and 35 if we have infection or draining wounds such as decubitus ulcers, bed sores. Back to Dr. Cage.
And then one of the things that we look at when it comes to calculating the fluid needs for our athletic population is, again, I keep coming back to this, but taking that individualized approach with these patients and making sure that we understand their sports and then also understand that individual's body. A lot of endurance athletes are what we call salt wasters. So they have a higher sweat concentration of salt. So as these individuals sweat, they lose more of their sodium and electrolytes through that sweat. So their dietary needs are going to be different than an individual that's not a salt waster. In our older adult athletes, we have to make those same considerations because some of your patients may still be involved in physical activity. So we need to take into consideration salt wasting, how dehydrated these individuals are, and then just understand some of the things that Dr. Jacobson's already touched base on about the physical changes that occur as we age.
So some practical interventions, certainly based on my clinical experience, if they have good oral intake, if they're eating well, typically water alone is usually okay. We need to consider frailty, especially like, as I mentioned at the beginning, some of the hypokalemic issues that can come around. In regards to treating the underhydration piece, I think there's some conditional recommendations that can be made in regards to adding some sodium, potassium, potentially calcium to some of these beverages. But you need to put that in the context of their clinical status and diagnosis and decide if this is appropriate for this individual. Oftentimes adding some of these things can help with some of the practical side of the flavor, the tolerance, the tolerability, right? If we go to the next slide here, again, some of the practical approaches in regards to beverage availability, to taste, the physical factors that may, the contributions certainly from dysphagia, different textures and tolerance, the medical history that we somewhat went into. Ultimately, water follows the solute and sodium is chief. So if we go back to those recommended or the dietary reference intakes of sodium, potassium, we know that most electrolyte recommendations are going to be lower in the older adults than it will be in younger and otherwise healthy people. So we're going to discuss next kind of how we consider some of these things in the context of different medical conditions. So if we go to the next slide, so for example, heart failure, hydration is vital. We've got to prevent kidney injury, we've got to prevent secondary heart issues. Kidney disease, again, somewhat of a chicken and egg, right? We know that hypohydration, a lot of sugar beverages lead to this hyperosmolarity, triggers a lot of vasopressin pathway activation. So the kidney is trying to restore back to normal, but because of the kidney disease, it doesn't respond normally, doesn't have as high an ability to respond. Different autoimmune diseases, we can see, again, both chicken and egg. Hydration becomes an even bigger problem with these patients because it can affect how the hematologic system responds to infection or inflammation. Endocrine disorders, the hypothalamus both influences feeding behavior as well as the regulatory control for a lot of these hydration and thirst feedback mechanisms. Dementia and mild cognitive impairment increase this risk for dehydration, but in turn, dehydration, like we've mentioned, decreases the cognitive performance. And then obviously the medications. 80% of patients on diuretics we know are clinically hypokalemic, but they may not all show initial signs and symptoms. So we need to consider all of these complex interactions.
And when we're trying to figure out how to be able to educate these patients better on the needs for them to be able to hydrate, in my professional experience, taking that individual approach starts with just going into that situation as compassionate and empathetic as possible, and understand that these patients might not know better, or they might think that they know better. And so we have to, again, reach that individual on their level. And what I've found with 18 to 24-year-olds, and in my experience visiting my wife when she's working in that SNF setting, there's not a lot of difference, and there's a considerable amount of overlap when it comes to the stubbornness between those two patient populations. But one thing that I've found always gets across to my patients is imagery. So that's why we have these pictures here, because I always tell my patients that dehydrated muscle is like jerky and hydrated muscle is like steak. And which one's going to be able to stand up to the rigors of what that person's trying to put that muscle through. And so you hear my patients sometimes at their practices as they're drinking water or their electrolyte beverages saying, we want to be steak, not jerky. And they kind of joke about it and give me a hard time, but they're still drinking water and they're still hydrating. And so I'm happy.
And I'd like to share very quickly what some of the research is saying about interventions. And basically, behavioral interventions are associated with positive effects on hydration and fluid intake. And I'll show you a few examples of behavioral interventions. So we're talking about things like verbal prompting or increasing choice and increasing availability of drinks. That's associated with improvement in hydration. And this is really interesting what the research is showing. An improvement in fluid intake of about 300 milliliters a day is both clinically as well as statistically significant. And I want to share this with you. We've used this before, but this is from the United Kingdom, and they did a study where they offered drinks at set times at least 7 times a day. Yes, 7 times a day. And they were able to reduce UTI hospital admissions by 36%, and UTIs requiring antibiotics were reduced by 58%. So the idea is to plan and schedule. That's an example of a behavioral intervention for structuring drink rounds around hydration. More examples of some planned interventions include calculating how much you deliver at meal, consider to be 75 to 80%. Then you need to come up with the rest of it for non-meal times and offer a variety of foods. Or scheduling it every 1.5 hours, or the sip and go intervention, where, especially for those who are reluctant to drink, every time someone comes into the room, they can offer a drink, or do it like MedPass, 2 ounces, 60 milliliters, taken when they see someone like a family member, or even during literally MedPass time. And don't forget about the fluid content of foods. We can promote more high fluid foods like soups and things like juicy fruits during for those individuals who need additional fluids.
One of the challenges we do experience, especially in long-term care, are the cognitive barriers, the barriers with assistance, and even the fear of incontinence. But we do have ways where we can better manage this. And reminding our residents with dementia to take a drink is not always a successful strategy. We almost need to pursue more of a coaching and provide direct suggestions using comments like, "You look thirsty, try this," or "What a hot day, try this drink," and actually putting that cup physically into the resident's hand. And doing this consistently so that we create a routine. I was at a nursing home last week and I just loved that one of the kitchen aides came in and said, "It's happy hour, here's your drink." And she passed that resident a cup that the resident knew what was in it, could hold it, could see it, and visually put it into her hand, so the resident was then able to do that. Now, one important thing we always want to remember from the speech therapy side of things is that thickened liquids do slow the flow of the liquid, and sometimes our residents need that. It can be beneficial depending on their diagnosis, but not to rule out the use of straws. Many folks really do better when they have that little bit of assistance to get the fluid into their mouth. What these brief examples, and Maggie, if you want to hit play on both of them at the same time, we can kind of do a compare and contrast. So you'll see the blue liquid on the left, which is thin liquid, and you will see the green liquid on the right, which is a mildly thick liquid. And what you're going to see during the swallows is that nothing gets into the top of that airway when the liquid moves slower. For this particular resident, that was beneficial, and they needed that extra time to be able to coordinate their swallow safely.
Ding. Thank you, Katrina. I know we're at the top of the hour. We want to be able to take a few questions, so I'll very quickly show you our key takeaways, which I'm sure that you've all been thinking about. You know, don't wait for that 3% body weight loss. Maybe 2% is the way to go. And some of those interventions about scheduling drinks is important. But let's move on to the questions because we might have a few. And for those who want to stick around, we can stay for the Q&A portion. Chris, are you seeing any questions?
There are no questions in the chat at this point.
Gigi, I think you might see one. Do you see any?
Yeah, I have some. Okay. What would be the main medication you would be mindful with that is likely to impact dehydration, reduced fluid intake?
Yeah, that's a wonderful question. I'll go ahead and take that one. I think there's probably multiple answers to this. I think specifically in regards to the fluid intake, you know, anything that can blunt that thirst response, anything that is associated with changing the flavor or the perception of texture, but then certainly anything, most commonly a lot of the diuretics, even though that's on the outflow side of things, promoting fluid loss without then also addressing the fluid intake piece. I think that's where, primarily because of just the number of those prescriptions that are written nationally, that's probably where we see the largest impact is from the pretty broad use of these diuretic medications.
Okay, the next question is, what about BUN creatine ratio?
Another great one to use. Oftentimes, those normal values can vary somewhat between laboratories. So knowing your facility's protocols, knowing your laboratory normal values, and then certainly if you are able to compare within a certain patient, a certain resident, changes over time can certainly be helpful. And then again, having a low threshold to look into some of those things so we can catch issues early in that process, hopefully when we have you know, ample time to reverse that.
Okay, the next one is, can you tell me more about hydration and electrolyte balance for individuals with POTS? How to estimate their needs?
I think this is another booming area of research that we've seen is the POTS, or the postural orthostatic tachycardic syndrome. I think we still don't have great large studies and data to support this, but I think this is another great intervention area that, looking at the specific individual's needs, there are certain circumstances, and like Dr. Cage was mentioning, really breaking this down to an individual level of how have they been sleeping? What are the other factors going into both their intake and their output? What else is happening, and what are they tolerating or not, can sometimes be just as useful as some of the objective laboratory urine or blood markers.
Okay, it says,
All right,
what about, oh,
we'll take
sorry,
this as the
Megan.
last one, Gigi. We'll take this one as the last
Okay.
question.
Okay. What about low sodium and fluid restrictions? I have patients being put on fluid restrictions for low NA, but they are already at such high risk for dehydration.
And we see this, unfortunately, all too often is fluid restrictions or sodium limits, either in the setting of kidney disease or heart disease. There's always a balance to be had. And I think trying to find support fluid intake without overriding some of the sodium restrictions is a challenge, and we certainly recognize that fact. I think incorporating the entirety of the healthcare team can be beneficial, and trying to find ways of implementing some of these fluid intake strategies and preventing excessive losses need to go hand in hand.
All right, thank you. Thank you. Those are really interesting questions and great answers. Chris, I'm going to hand it off to you to close us. Chris, I think you might be.
Okay. Yeah, no, I'm sorry. Yes, so thanks our participants for attending and this ends our webinar. Just want to be close. There's a, I guess Maggie, I'm not sure where we go from here. I apologize.
We're just going to say goodbye to everybody. Thanks for attending. We got some references here for you. And we'll see everybody at our next webinar. You'll be getting emails from us with your CEU tomorrow. Thanks, everybody.